Biopsied previously as a grade 1. We've taken thoracic radiographs and those came out clear. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone when we live stream. So what I'm doing here is I'm going to do a wide local excision. It is somewhat movable, but I am going to take some fascia out from underneath the tumor, and then depending on how much tension it's under, I'm probably going to do a little flank fold flap from here to close the defect, either from here or from here. So I'll just start my excision up here. And I can't see the screen, so I may not answer your questions right away, but Tiana, our anesthetist, if she has a minute, can read questions to me off the screen.
You've just got a few people saying hello.
Thank you. So that's biceps muscle right underneath, which is what we'd expect to see there. What we find is that when we cut these things out, what you think is a 2 centimeter margin, the skin contracts on the inside and the hole expands, and so what you thought was going to be a 6 centimeter hole turns into an 8 or 10 centimeter hole. And so it's always a good idea to be prepared. You can see how that skin is expanding outward, pulling outward, and so it's making that hole bigger. So when we go to remove these things, we always have to remember that you're going to have a bigger defect than what you imagined. And so you have to think about ways to reconstruct before you get into theater, so that you're not not having to cut through unprepped and unshaven skin, stuff like that. I don't have an assistant here today because we're quite busy. Not used to having to cut by myself. It's very lonely. I might have somebody join me later. So grade 1 soft tissue sarcoma, the metastatic rate is only about 5% on these. Might be breathing up a bit. Thank you. Hi, Christine from Virginia. Hi, Stephanie. Hi, Taylor from Idaho. Yeah.
Are you all right, or do you need somewhere to go?
I mean, it would be nice if we had a spare, but it's certainly not critical. If it's going to make it easier to get the next patient down, then don't worry.
Okay.
Yeah, that's fine. So I'm just going through the external fascia of the biceps muscle.
We're just going to try and get the IV in.
All right. So now what I'm going to do is come underneath with a Metzenbaum, and I'm just trying to take the muscle fascia, trying not to take any of the depth of the muscle, recognizing, however, that if we had to take the entire biceps muscle out, the function would be completely fine. Might not be able to run quite as fast as the other wild dogs on the African savanna and compete for food. But if the only competition is between siblings in the household to who can get to the dog food bowl, I think this dog will be fine. Or a dog in which you remove the entire biceps muscle. technically it's actually easier to remove the whole biceps muscle than it is to try to just get that fascia off. And I don't want to penetrate the fascia for fear of contaminating my surgical bed. All right, so that's the mass removing. You can see that we've got a nice margin of muscle and muscle fascia deep to that. Can I get bupivacaine, please? So I'm going to do a little local block of bupivacaine.
How much do you want?
About 4 ml. All right, so could I close this primarily? I probably could, but it will be under a bit of tension. So I'm just getting my bupivacaine now. And sorry, I see that there's some questions. The cautery unit, I don't really care what brand it is. This one is a Valley Lab, an old unit. I just like the old human units. They're really robust and reliable. You can get like a 30-year-old unit and it's still going to work really well. And you can drive a truck over them. So that's what I like to use. You can buy a new unit. If you're going to get one with a vessel sealing device, that's great as well. Like a force triad. And cautery pencils, again, it just doesn't matter. They all work the same. All right, so that's my local block. Now, the skin flap that I'm going to use is a flank fold. And basically what I'm going to do is I'm going to take a fold of tissue here in the flank, just grab onto it with some towel clamps. I reckon that's going to be the go right there. And what I want to do is I want to make sure that I can pinch together whatever it is I'm cutting out, so that I make sure that that I'm going to be able to close the donor site. And as far as length is concerned, basically that's the pivot point right there. And so I want to stretch that around up to about there. So it's almost like if you had a compass. So the end of my flap is going to be right there. And I'll tent this up a little bit here and just palpating to see what I'm going to be able to pinch back together to close easily. I'm going to stretch it out a little bit more because I'd rather it be too long than too short. So that should close together nicely. And then I'm going to have to make a bridge incision, kind of like that, to join the flap to the recipient site. So I'm pretty happy with the appearance of that. I can take off my towel clamps now. Is that going to stretch? Just checking again to make sure that I'll be able to close that defect, and I will. All right, so now it's time to harvest the flap. So I'm just going to come up over the top here. Like that. You guys all good?
Yeah, just wrestled that.
Great Dane. Was he being good?
No, he was being good, but I couldn't eat a bridge over the IV. I had to run around him. So he will have lunch. But you take care. Yeah, seems to be fine.
Mia, one of our vet nurses, who's petite to say the least, is wrestling an 86-kilo Great Dane to try to get a catheter in. Alright, so stretch this down like this.
So she started to breathe now. By herself, but we have to start to give her issues. So it's not ready. I'll just put her on the child
I'm going to try to keep as much tissue with the flap as possible. That vessel that I just cut there is the deep circumflex iliac, which is the basis for is a direct cutaneous artery for a axial pattern flap. Branch right here. And so there's just a lot of redundant blood supply to this flap of skin, which is why flank fold flap is my favorite reconstructive flap. It's so robust, and there's a lot of redundancy. So that's going to come across there really nicely. And then I just need to cut my bridge incision, get rid of that skin. What I'm going to do is elevate that bridge incision on one side. Keep the other side intact, just on the off chance that I need it for some reconstruction. So I'll just elevate this. Now, if there's any question about the completeness of your surgical margins, you should be using a new set of instruments to harvest your flap, because you don't want to contaminate the whole surgical field if you have dirty margins. I'm 100% sure that I got a clean margin on this from experience. All right, so I'm saving that just in case. I don't know that there's anything I could use it for, but if I need it, it's there. All right, so now I'm going to bring that across here, and I'm just going to use some little towel clamps just as a temporary fixation. Just to make sure that everything looks like what I think it should. Can I please have some 2O PDS? Squirt a little bit more. Do you know what, do we still have that bupivacaine? Or did we chuck it?
Or did you use some?
Oh, it's over here. Can I just get some more of that, please?
Yeah.
Thank you. Okay, thank you. So where I can, I'm going to try to close this in 2 layers. I'm used to having an intern or a resident that can help me close. It's been a long time since I've had to close something completely by myself. I have been very spoiled. The cautery unit I'm using is, I'm sorry, the level is, I think it's 30 watts or joules or whatever it is. If you have a minute, Mia, can you please go back through and see if there are any questions that I haven't answered? You'll just have to sweep up. If we're going to have a problem with dehiscence here, it's going to be in the donor site, not the recipient site.
Do you know what the last question was? Have you done the, do you use the flat technique for that?
Yeah, keep going up.
You've answered the procedure. What is the procedure?
Yeah.
Regarding lower-grade soft tissue sarcomas, even if the excision is complete, margins clear, is there any follow-up recommendations?
So for low-grade soft tissue sarcoma, if you've got a clean margin, there is no follow-up required. I mean, just monitoring for local recurrence, but the risk of local recurrence following a clean excision on a soft tissue sarcoma is only about 5%.
What is the brand and model of cautery scalpel you use?
Yeah, already answered that.
Oh, yes. Can you undermine the skin to reduce the tension and flows primarily?
I have done that before, and what I find is that it doesn't reduce the tension enough and so I still have dehiscence from excessive tension. And so I have found that the flank fold flap is a really simple solution that does not increase morbidity significantly and really reduces the tension on the flap and the likelihood of complications.
If you're doing a flap, how does the electrocautery affect the acceptance of the flap on the primary surgical site? I would think the lack of bleeding might inhibit healing.
So good question. The question is, does the use of electrocautery affect the survival of the flap? And I find that judicious use of electrocautery does not, as long as you're not cauterizing in the middle of the underside of the flap.
How many days this patient will stay in residency after the surgery?
So I would like this dog to stay overnight. Unfortunately, these owners have driven from a long way and they are really hoping to take her home tonight. I'll see how she's doing a few hours after surgery. And my advice is going to be that she stay, but I think these owners have their heart pretty set on taking her home. That's why I was really careful about doing a very robust local flap to provide some good pain relief and to try to prevent windup. We'll also send her with give her one last injection of methadone before she goes home, and then we'll send her with some paracetamol and meloxicam. Probably some codeine as well. The question about the electrocautery and the flap, remember that the blood supply to this flap is not coming from the edges, it's coming from the base of the flap. And so electrocautery around the edges is not going to cause a problem.
Do you worry about the point in the tissue?
About the what?
The point in the tissue?
The point.
Do you worry about the point in the tissue?
So this area here, if you're going to have dehiscence, is where it's going to be, is at that corner. I assume that that's what you're talking about. The best surgical oncology textbook that I know about is probably Simon Kudnig's textbook of surgical oncology. I don't know how he's had time to put that textbook together. Julius Liptak has also is just putting the finishing touches on his textbook of surgical oncology. And again, don't know, I mean, Julius has just opened a new hospital as well and has a kid and is married and blah, blah, blah. So it's amazing that they have the time to do that. So the mediastinal mass, thanks for asking, came back as a chemodectoma still. I'm a bit skeptical, but that's what the pathologist called it. And it's doing very well. Although it's still coughing. It presented initially for a cough, and as I warned the owners, I couldn't guarantee them that by doing this surgery we were going to resolve the cough. And we didn't. And so I've sent them for a workup with an internal medicine specialist to try to determine if it has collapsing trachea or small airway collapse. Can I please have some more 2O PDS? Yep, thank you. It's probably a branch of the geniculate artery. There's a question about, is there a concern with continuing my simple continuous from the donor site into the recipient site? Look, you make a good point. I'm not overly concerned about it because I don't think this is under a lot of tension. I did put in an interrupted right about there just to try to separate the two lines. Yeah, this is definitely the point at which having an intern would be great. That they could close the incision and I could get a coffee.
Would be nice, wouldn't it?
Yeah. You just tell me if there are any other questions.
You answered, would doing a continuous pattern from donor into recipient site run an increased risk of
Dehiscence, yeah, I just answered that, yeah.
Oh, you answered that?
Yeah.
Do you not use tramadol for home?
So tramadol, I don't think is particularly effective for pain relief in dogs. Maybe a little bit better in cats, but I think we've got other things that are more reliable. Like we use a lot of paracetamol and meloxicam in combination. So tramadol is not reliable in providing pain relief in dogs. The resorption is unpredictable, and the ability to provide pain relief is unpredictable as well. I did a e-learning module on exactly that topic about 2 weeks ago. If you want to email me at ckuntz1@mac.com, CKUNTZ, the number 1, at mac.com. I'll put you on our mailing list. And then you can access that e-learning module. So CKUNTZ, the number 1, at mac.com.
Do you alternate Tylenol and meloxicam or both once per day?
So meloxicam is once per day. Paracetamol or Tylenol is every 8 to 12 hours. And the dose for paracetamol or for Tylenol is around 15 milligrams per kilogram. Some people go as high as 30 milligrams per kilogram when given orally, although I don't. I tend to stay around the 15 mark. But paracetamol is one of the safest pain relief medications that we have for dogs. Totally unsafe for cats. A single pill can reliably kill a cat, but in dogs it's completely fine. I've been using Tylenol in dogs for around 25 years without a single issue to my knowledge.
Surgery and answer questions at the same time?
I'm multitasking. Like if I was in an important part of the surgery, I would not be answering your questions. Like a part that required a lot of thought.
Is meloxicam a better choice than flunixin?
Yeah, so flunixin is much more likely to cause gastrointestinal complications in dogs than meloxicam. I wouldn't give flunixin in dogs. Can I get another pack of 2O PDS, please? Thank you.
What is your post-operative care protocol, and do you apply any bandages until suture removal?
So a bandage, we would do like a Primapore Band-Aid, probably for 3 days. Restricted activity for 2 weeks, pain relief for about 7 days, no antibiotics post-op. We're giving antibiotics intra-op here, but not post-op. And that's about it. Short leash walks, 4 or 5 times a day to do their business and to keep them from getting too bored. But that's about it. Recheck at definitely 14 days and then at 7 days if the owners have any concerns. And one of the reasons why I can answer questions while I'm doing surgery is because I'm so used to my nurses asking me lots of questions.
My emergency did a long continuous. I would be too worried about small area of
Dehiscence?
yes would ruin the lot.
Again, the weakest part of the suture line is the knot, and so a simple continuous is actually quite a robust suture pattern. So dehiscence by itself is not going to release all the other sutures. You're still going to have tension on that suture bridging. Sometimes if you have a dehiscence and you have a loose bit of suture, sometimes we'll put in another suture and tie it to the end, the continuous end. Do you know if they've started on the cruise ship?
No, they wouldn't have 2 hours on lunch.
Okay. What time is it getting? 1:30? And did Tegan call in sick, do you know, or was she not scheduled today?
Not scheduled.
Right.
Would you tack down any dead space in the middle of the donor flap?
So you cannot tack down to the donor flap because you might damage the blood vessel. So I don't close dead space on these. If I'm worried about a lot of dead space or a lot of serous drainage from the bed, I will put in a Jackson Pratt drain, but most often I do not.
I've been wondering but can't find any good answers. Can you use paracetamol for post-op GI surgery? Everyone here uses gabapentin, which I feel is pretty worthless.
Yeah, you can use paracetamol for post-op GI surgery. I've never heard of any contraindication to that. Gabapentin is fine as an adjunct to other pain relief, but I don't think, probably doesn't do enough on its own unless the pain is nerve pain, like post-spinals or pre-surgical spinals, that kind of thing. I think gabapentin can be pretty helpful.
Did anyone catch the email?
Did somebody email me and they're checking to see if I've already received it? Is that your impression? Because I'm kind of busy right now.
Yeah, I don't know. Did anyone catch the email?
I promise you I will check as soon as I get out of surgery. because prophylactic post-op antibiotics do not reduce the incidence of infection, and if you do get an infection, it's just going to be resistant to whatever antibiotic you had them on. And in this day and age of antibiotic resistance, we really need to reduce the amount of antibiotics that we're using in dogs. Otherwise, we're going to run out of any antibiotics that we can use on anything, number one. Number two, the FDA or TGA or whatever the regulatory body is in your area may decide that they're not going to let vets prescribe anymore. Because if I can promise you that if their main concern is human antibiotic resistance, that the use of antibiotics in animals is going to be the first to go. So we have to be responsible with our antibiotic stewardship. Trying to bury this knot. Not sure how successful I'll be.
I think they were asking for the email address again.
Oh, it's Ckuntz1, so C-K-U-N-T-Z, or Z, the number 1, at mac.com. M-A-C, as in Mike Alpha Charlie.com. So Ckuntz1 at mac.com. And that is pretty much it. I'll just go back and make sure there aren't any questions that I've missed. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications. The patient is completely anesthetized, so deep stage of anesthesia. So that's an interesting question. We don't have an anesthesiologist on this patient. We have a nurse anesthetist. And a palpable femoral pulse, I generally associated with a mean arterial pressure of about 60 millimeters of mercury, although I've had lots of people tell me that that's not reliable. So that's kind of a guess. You know, if you can feel a femoral pulse, that implies to me that you have a reasonable blood pressure. I'm just reviewing questions. Yeah, so the question, that is why I tied off at the corner before I continued. All right, so I'll go ahead and wrap it up. Again, if you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so that you'll get a ding on your phone the next time we live stream. We'll see you again soon.